been some recent good papers in last issue of JACC, and that describes right from the pathophysiology till the therapeutic and probably a preventive measures that we have come across. So we'll start with that. We all know that aortic stenosis is something that a cardiologist comes across daily. So according to the popular studies, the incidence.
First, we did that valvular aortic stenosis.
Yes, we are talking
Not
about
supravalvular or subvalvular.
No, we are talking about valvular.
Am I right?
Perfect. So,
Because then the whole paradigm shifts as such.
definitely. So specifically we will be talking about valvular aortic stenosis, and the incidence according to the popular study is about 1 to 2%, 65%.
Slowly. Neurons पैदा गया है
at around 75%, about 12% of the people they tend to have aortic stenosis, and out of those 12%, about 3.5% will have a severe aortic stenosis. Now the prevalence of aortic sclerosis, that is valvular degeneration without significant gradient, is about 9% at mean age of 54, and it increases to as good as 42% at the mean age of 81. According to the traditional studies, someone who is having aortic stenosis, the likely rate of progression to severe aortic stenosis is about 1.8, 1.9 per year. Traditionally, we all know that there are three main causes of the valvular aortic stenosis. That is the congenital bicuspid valve getting later on calcified and getting stenosed. The second one is the calcification of the valve, and the third one is the rheumatic heart disease. These are the three main causes that we come across as the aortic valve. Now, this is in the brief the pathophysiology of aortic stenosis. What are the risk factors? We can see dyslipidemia, smoking, diabetes, renal insufficiency, or maybe the native valve morphology is more liable to get stenosed. Then there is of course some shear stress, inflammation, lipid deposition, then it gets oxidative injuries, eventually calcium deposition, cartilage deformation, and stenosis of the valve. We all know this classification, the hemodynamic classification of aortic stenosis. The stage A is at-risk aortic stenosis with the classification is mainly based on the echo parameters with the Vmax of less than 2. Then the stage B is that of the mild and the moderate aortic stenosis. Stage C is asymptomatic severe aortic stenosis. What we are going to discuss today are the different stages of symptomatic aortic stenosis and how the pathophysiology or how the prognosis works. So, the hemodynamic or the echocardiographic criteria of the severe aortic stenosis. That is the valve area less than 1 centimeter square, peak velocity more than 4 meter per second, and the aortic valve gradient more than 40 mm of H. So now onwards we call this traditional classic high gradient aortic stenosis, severe aortic stenosis. We'll mention it as high gradient aortic stenosis. Now again, as per the popular studies, you are likely to miss somewhere around 40% of physiologically or severe aortic stenosis if you just follow this echocardiographic definition of severe aortic stenosis. So what are those? They are the different categories of low gradient aortic stenosis, and mainly divided in among three groups: classical low flow low gradient aortic stenosis, paradoxical low flow low gradient aortic stenosis, and normal low flow low gradient aortic stenosis. I have defined all these three in the coming slides. So we'll just move forward.
What is this?
So I have this.
It is the physics. It is the physics.
Yes.
See, you are going to discuss the physics.
Yeah. Okay.
Right?
Yes.
You are going to show me the flow and velocity.
Yes.
Right?
Yes.
So that is the physics. Huh? And we don't ask physics to take in a standard way.
Yeah. Okay. This figure we have seen in all our Harrisons and Dorvals and every textbook that we study in cardiology. Now, mostly we are looking at this figure, and what I want to say is this one is the traditional severe aortic stenosis with Vmax of more than 4 meter per second or a mean gradient more than 40. And this is how the prognosis is plotted. And the low gradient aortic stenosis, though the prognosis is not that great, graphically it seems slightly better according to traditional studies in the low gradient aortic stenosis. Now this is the important study that has been published.
These are all asymptomatic.
Yes.
Right? So
Yeah.
symptomatics are different than asymptomatic.
Symptomatics are different. But in this particular graph, most of the patients are likely to be symptomatic because they are with a very high gradient.
They have shown the only asymptomatic.
Yeah.
This, because symptoms related on physics again amplified.
Okay. So this is the study we are going to look upon basically mostly today. This was published in the last month of JCC, and it divided the different categories of low gradient aortic stenosis and so how that performed, how the pathophysiology and prognosis developed over the phase. About 3,369 patients were in this part of the study, and they divided the different group of low gradient aortic stenosis as per the definitions. Low gradient aortic stenosis with reduced, and we have classically known as a no flow low gradient AS with a Vmax of low gradient and Vmax of less than 40 and mean gradient of less than 40 with aortic valve area of less than 1 and an EF of less than 50%. Now comes the paradoxical low flow low gradient. Again the same Vmax of less than 4, gradient of less than 40 and valve area of less than 1. But now we have the EF which is more than 50%. And the index stroke volume, again calculated by echocardiography, is less than 35. What is a normal flow low gradient AS is again the low velocities with preserved EF, but here the stroke volume index is more than 35. So basically the flow across valve is echocardiographically normal in this variety. And the classical high, severe aortic stenosis with velocity is henceforward mentioned as a high gradient AS in this discussions. So this is the study pattern, and they took about 300,000 plus patients and divided it into the different categories of aortic stenosis. About 8 patients had the classic low flow low gradient aortic stenosis. About 7% had a paradoxical aortic stenosis. About 26% had a normal flow low gradient aortic stenosis, and the classical high gradient aortic stenosis was in about 60% of the patients. And some of the patients were offered with initial surgical or transcutaneous therapies during the beginning of the studies, and some of them were managed conservatively. So about 48% of the patients from the studies, they went for the conservative strategy, and 52 patients underwent, approximately 52% of the patients underwent either SAVR or TAVR at their first index consultation. The follow-up was started from the day of consultation, and approximate mean follow-up was about 2 years of period. Primary outcome of the study was the death and symptomatic heart failure hospitalization. The heart failure definition was either it was a hospitalization required intravenous drug therapy. So now we see the baseline clinical echocardiographic and CT characteristic of the different low gradient aortic stenosis. These are the charts. I have mentioned the necessary information in my slide, so we can skip on this part if the value time, and when required we can always come back to this. So the classical low gradient aortic, low flow low gradient aortic stenosis, at the end of 1 year about 47% had the SAVR or TAVR, and at the end of 3 years more than 2/3, that is 64.5% patients exactly underwent surgical or transcutaneous aortic valve replacement. Paradoxical, about 36% at the 1 year and about 60% at the 3 years. Normal flow 32% at 1 year and about 54% at the end of 3 years underwent either SAVR or TAVR. In the high gradient AS, 77% underwent SAVR or TAVR at the end of 1 year, and at the end of 3 years, roughly around 90% underwent some sort of intervention. Now, the death and the hospitalization, the primary outcome of the studies. There's a lot of data, so
You can remember those data.
yeah.
See, because we are hearing only, then same thing can happen at home only,
Yeah.
on Zoom.
No, we'll try to make it more interactive.
Correct?
Yeah.
So we just close it as such. You read it, we sleep it. Sorry.
No, we'll try to make it more interactive. So,
Go ahead.
So now we'll see how the different categories of the low-gradient aortic stenosis perform as compared to the traditional high-gradient aortic stenosis. But statistically, most of the patients were managed that they had more cardiovascular comorbidities present, and the echocardiographic heart fragility and severity of cardiac damage was more in those patients. What about the echocardiographic parameters? From the low flow low gradient aortic stenosis, 47% of them had a stroke volume index of more than 35. So in those patients, actually the flow across valve was mentioned, and hence the classical low flow low gradient term has been now changed to a low flow aortic gradient with decreased EF. Again, these parameters basically the valvular area measured echocardiographically was slightly higher as compared to the standard severe aortic stenosis, and the end-diastolic volume and LV mass, of course, they are higher, indicating the more severe cardiac damage in those patients. This third point, high prevalence of moderate to severe valvular disease, is basically related to the other valves. So that was the miss. Two investigations we do to differentiate the valves, whether it's true severe aortic stenosis or it's just a low gradient aortic stenosis, not severe. Those are, one is the abdominal stress echo, and the second is the CT scan. In CT scan we have something called an Eggleston score, and traditionally that score should be more than 2000 in man and about 1200 over 1200 in woman to state that valve is a severely stenosed valve. But as we can see in these studies, those who had hemodynamically significant low gradient aortic stenosis, their CT score was way below the standard criteria for severe aortic stenosis, with a mean score of 1447 units as compared to 2000 plus in the standard variety of severe aortic stenosis. So CT might not be a good investigation to look for this. Clinical outcomes and the surgical recommendations and clinical outcomes. The current guideline, symptomatic low flow low gradient aortic stenosis confirmed by dobutamine stress echocardiography is a class 1 indication for AVR or TAVR. Again, the same data. At the beginning of study, about 32% underwent surgery, and at the end of 3 years, about roughly around 64% of patients underwent surgery. Clinical outcome in the respect of the primary outcomes, higher rate of death and heart failure hospitalization. Cumulative incidence was about 66% in the low flow low gradient aortic stenosis at the end of 3 years as compared to the standard high gradient severe aortic stenosis. Almost the double incidence of heart failure hospitalization and death in the low flow low gradient aortic stenosis. So if you can clearly see that, we just see the gradient in labels of patient with a moderate aortic stenosis, and we all know that the moderate aortic stenosis is not an indication or another class of indication for any intervention, and we leave that patient as it is without any DSE or without any CT studies. Then we are putting that patient to double the risk of primary outcomes, that are heart failure and the death. Now we'll see the second variety, that is the paradoxical low flow low gradient aortic stenosis. That is the low gradients with preserved EF and decreased stroke volume index variety. Again, the echocardiac fertility was more in those typically to predict the outcome of aortic stenosis patient. And the normal is the absolute normal heart, then the grade 1 is LV dysfunction, grade 2 is LV dysfunction, grade 3 is compensated right heart failure, and grade 3 was decompensated right heart failure. So that fatality was more in the paradoxical low flow gradient aortic stenosis as compared to the standard gradient aortic stenosis. Aortic, the prevalence of atrial fibrillation was more than, let's say, about 3 times common as to the standard high gradient aortic stenosis, the paradoxical low flow gradient aortic stenosis patient. Again, the echocardiographic parameters would show a slightly higher or slightly more aortic wall area as compared to the standard aortic stenosis. More of concentric remodeling of LV. And again, the CT findings that are not falling in the severe category. So again, the CT would not be a good investigation to label the patient as a severe aortic stenosis in this variety of as per the current situation. Now, again, those patients who had atrial fibrillation and paradoxical low flow low gradient aortic stenosis, obviously they had more heart failure hospitalization and they had more LA dysfunctions and mitral regurgitation. That is like can be well. So again, how they underwent the intervention. Initially, about 30% of them underwent valvular intervention at the end of 1 year, and at the end of 3 year follow-up, about 60% patient underwent some sort of intervention. The primary outcome, again, we can see it's way more than the traditional high gradient aortic stenosis. The incidence of death and heart failure is almost as good as double as compared to the traditional heart failure. Now, this was outcome unfortunately was that both the categories of patient who underwent either interventions or they did not underwent the interventions, the primary outcomes remain the same in both the groups. What are the guidelines? Again, severe symptomatic paradoxical aortic stenosis, low flow aortic stenosis with grade 1 indication possible. Again, those patients who had atrial fibrillation along with paradoxical low flow low gradient aortic stenosis obviously had much worse outcome at the end of 3 years with higher incidence of primary outcomes. Now we come across the third category. Normal flow low gradient aortic stenosis versus high gradient aortic stenosis. That is a low gradient preserved EF and a preserved stroke index volume echocardiography. Statistically speaking, patients had higher range as compared to the standard high gradient aortic stenosis, and most of them were female patients. They had a smaller body surface area and they were less symptomatic as compared to the traditional high gradient aortic stenosis. Again, stage 3 and stage 4 cardiac damage, echocardiographical imaging was more prevalent in those patients as compared to the traditional aortic high gradient aortic stenosis. And again, the CT evaluation did not help in those patients also. The clinical outcome in those patients were relatable. Again, the intervention rate at the end of 1 year about 23% and at the end of 3 years about 70% of them they have some sort of intervention. The primary outcome was comparable to the traditional high gradient aortic stenosis. About 36% of the patient had either heart failure hospitalization or death over the period of 3 years as compared to in about 30% as in the traditional high gradient aortic stenosis.
What is the survival rate of low gradient TAVR or SAVR compared to high gradient?
So survival rate, I don't know the exact figures, but apart from this study, other studies also that have come across, they show that the survival rate is poor as compared to the traditional high gradient aortic stenosis.
See,
And the mechanism, probable mechanism would be the associated advanced cardiac damage.
see two ways I look at it. One is the mortality and one of the morbidity. One of the phenomena of aortic stenosis is the survival.
Yes.
Right?
Definitely.
Whether we have altered this thing or not. That's the one thing. People don't talk of a syncopal attack. Right? Otherwise, in aortic stenosis, syncopal attack is another phenomenon.
Yes.
Everybody concentrate on angina and cardiac failure.
Yes.
Other two parameters of aortic stenosis are not being well studied or addressed.
Definitely. That adds to a lot of mobility.
Then suppose after TAVR, let us say after 3 years, if a patient develops syncope, do you think the valve should be again replaced?
No. The replacement would entirely based on the investigations, how the valve is performing hemodynamically. We measure it through echocardiography or any other issues with the valve, whether that's a paravalvular revegetation, whether there are severe venous formation. It will not depend on whether the patient has any syncopal attack, because the syncopal attack could be due to some other thing also. Of course, with the symptoms, there is severe hemodynamic degradation in the valve, then those patients do go re-interventions. And nowadays, all sort of re-interventions are possible. Even in the last year, there was a published patient, they have tried tower in traditional metallic mechanical valve patients also. And those are like the usual case reports.
And the issue is, it is a dynamic process.
Yes.
And you see the patient, not the aortic stenosis.
Yeah.
Now, when the person age advances, he may start having carotid stenosis also. And syncopal may be because of that also. And the,
So, yes.
mean that it should be a holistic approach rather than, because once he has gone for a TAVI, every time you concentrate on TAVI.
Of course, sir. No, like we have to see for the other causes also.
Absolutely.
And the re-intervention will solely based on the investigation evidence of degradation of the valve function.
You should see the whole picture. See,
Yeah.
anemia. In India it is very common. And
Very
everything
common.
is very common. Now
Typically,
the aortic
anticoagulation
stenosis,
because
syncopal
of
attack.
anticoagulation, sir. So, what happened was, in the normal flow low gradient aortic stenosis, those who underwent the intervention, either SAVR or TAVR, they didn't show any significant improvement as compared to the high gradient patient who showed significant improvement in the primary outcomes, and the possible mechanism was associated cardiac damage in those patients, and probably the aortic valve itself was not responsible for those heart failure. So basically, in this category of patients with normal flow low gradient aortic stenosis, first you, as sir has mentioned, see the patient entirely and try to find out all other causes of heart failure and symptoms of the patients. Try to treat that causes. Only after that, if the patient is symptomatic, then go for the valvular intervention. Because traditionally, this normal flow low gradient aortic stenosis is a moderate aortic stenosis, as you all know, with a low gradient preserved AF and a normal stroke volume events.
Once AF starts, sir, atrial kick goes away. That cardiac part of the cardiac output is gone.
Yes.
Now you entered into a vicious cycle now.
Yes.
See, your ejection fractions and everything, your gradient changes because now the cardiac output is not there.
Yes. So that's a flow chart. Let's say you have come across a patient with a low gradient aortic stenosis. Then how do you go about it? Came across a patient with aortic stenosis and mean gradient was, let's say, around 30, 36. Vmax was less than 4. First of all, first and foremost thing to do is check your routine echo, whether it's been done perfectly or not. Even mismanagement in the SBOT measurement can change the entire aortic valve gradient and hence the classification. Secondly, you take the gradient with multiple windows. Thirdly, if possible, you do a 3D equal, see the valve areas. Again, this 3D in the traditional guideline has been mentioned, but as we have seen in this study, is not going to help with the low gradient aortic stenosis to define whether it's really a severe stenosis valve or not.
These whole data are observer dependent.
Yeah.
So now AI will come here.
Definitely.
Take it from me.
Yeah, definitely.
Huh? Because some fallacies of the two observers' data may alter the whole paradigm shift.
AI is very likely to see the entire picture, how the clinical parameters, the age, sex, the diabetic patients, they perform in similar group of gradients and similar comorbidities. AI is always going to be better.
So prevent your mindset to change. See, that's the whole point.
So now we'll move to the second part. What are the advancement in the treatment of aortic stenosis? I'll just go about 2-3 studies of Tower that has been present recently, and those have been taken from this again the recent article from KCC, and that article itself talked about 3 recent studies, and we'll look upon those studies in very brief manner. First study, systolic heart failure. That is EF less than 50%.
Over the time they changed the name. Previously it was Tavi.
Okay.
Now it is Tower.
So this is rather the more interesting part of the discussion. Patients present with heart failure and a moderate aortic stenosis. You are treating the heart failure, they are still symptomatic and coming through. And there is some moderate aortic stenosis, and you think that treating that aortic stenosis is going to have a Of course, the study included only the Tower, not the Saga treatment. Same concept as I was talking about. First, you need to manage the heart failure component, and then look for the presence of aortic stenosis. How did the study go? The study included about 190 patients, and they divided those patients into 1:1 ratio. 50%, about 50% of them underwent just observation, and 50% underwent Tower. Study spread across 2027 to 2022. About 178 patients with a mean age of 77. 20% of them were female, and those who had NIHA grade 3, grade 4 symptoms. After the interventions, the observation period was follow-up period was about 2 years. 42% of the careful observation patients eventually underwent Tower. We will not go into much details. We will just see the primary and outcomes and how the study performed. Primary outcomes were all-cause death, stroke, and heart failure hospitalization, and KCC's questionnaire of quality of life. There was no significant difference among death, stroke, or heart failure hospitalization in the patients who underwent those interventions. But only part that was improved, that was quality of life, was better in those patients who underwent Tower rather than those who didn't went. Of course, the physiological explanation was that the LVEF was still there, and hence the LVEF related morbidity and mortality was still there.
Probably long-term.
But again, long-term intervention will definitely have, because this is just a 2 years follow-up observation. So again, we need to see those patients for long. This is the second study we will look very briefly on this. Severe asymptomatic aortic stenosis. We all know that it's not a class 1 indication to operate those patients with severe asymptomatic aortic stenosis and a preserved left ventricular function. Those kind of patients who underwent Tower, and those were compared with the same category of patients who underwent careful observation. Again, the study included, there was a meta-analysis of about 1400 plus patients, and the average duration of the follow-up was 4 years. Now, this is the best part. That study showed the unplanned heart failure hospitalization was much less in the patient who underwent Tower, who had asymptomatic severe aortic stenosis. They had much less incidence of stroke. All-cause mortality was also not statistically, but was slightly lower than those who didn't find Tower. So again, in asymptomatic severe aortic stenosis patient, Tower could decrease heart failure hospitalization, stroke, morbidities of the life. Death might not be statistically improved. The third category, transcatheter
It
versus
can improve the kidney function also.
definitely
See, low output
straight
again is
always.
the detrimental.
Yes. Again, the third and the last study that we are going to see are TAVR versus SAVR in the low risk patients. Again, we'll just look at the outcome at the end of 5 years. TAVR had a 20% reduction in all-cause death as compared to SAVR, surgical aortic valve reduction, and about, let's say, about similar 20% reduction in debilitating stroke incidence as compared to the traditional surgical aortic valve replacement. Those patients who are also having not very high surgical risk, somewhere around 70 years of age, TAVR would be better choice for them to prevent all-cause death. And
Who sponsored this study?
these studies were not sponsored by.
Conflict of interest.
No, there were no conflict of interest. These are basically meta-analysis studies.
No, again, but then they are recommending TAVI more than the surgical aortic valve replacement.
Yeah.
Hmm?
I have not mentioned it, but again, we can just go forward and see those papers, and they were not sponsored anywhere by the.
Sometimes the big risk are written in a very small letter. Like a mutual fund.
So, lastly, there was some recent study, and what we'll do is we'll go to the last slide of that study directly, because to avoid any confusion. Basically, SGLT2 inhibitors were given to some patients who had severe aortic stenosis, and some patients did not receive any SGLT2 inhibitors. The mean therapy period of SGLT2 inhibitors was 1 year in those patients who underwent the SGLT2 inhibitors. And the study is, the follow-up period of the study was 2-3 years. So again, we know that that is not a good period to comment upon increasing the severity of aortic stenosis from the sclerotic lesion. But what the study will help, the clinical implications of the study, that we know that some patient is having diabetes, is having aortic sclerosis in the core. Then we might just give that patient SGLT2 inhibitor, and it just might halt or decrease the progression of sclerosis aortic valve stenosis. Now we come to the first page. The possible mechanism of, we know that the oxidative injury and the lipid accumulations are the two pathophysiological factors in the development of aortic stenosis, and the SGLT2 inhibitors are likely to act on those parts. So that study included somewhere around 11,000 patients. Out of them, very low fraction of patients, roughly around 500, who had SGLT2 inhibitors ongoing, and the mean treatment of SGLT2 inhibitors was 1 year. The follow-up period of the study was observed till at the end of 3, 6, and 12 months, and up to 2 years in those patients. And we can see that the no SGLT2 inhibitors had a graphically more common development towards the severe aortic stenosis as compared to those who did not receive an SGLT2. Again, the follow-up period of 2-3 years is not good to comment whether, and as well as the duration of the therapy is not that high, just the 1 year of SGLT2 inhibitor and 3 years of follow-up. But the initial results are showing somewhat good phenomena.
BMI?
BMI? No, I have not gone through those. Even they have not mentioned the BMI.
I am putting the same thing as this.
Yes.
Huh?
And this is again the traditional therapies for proposedly they were given
So it may
to.
be working with a different mechanism than what SGLT2 inhibitor.
Yes, not traditionally the glucose management.
Right.
The oxidative injury and the.
Something different.
Yes.
We just label beta blocker is this. Person Bhai is the physician, not the husband of her wife, yes, not the father of his children. We label that thing as such.
this study was only that maybe you come across those patients who already have indication for SGLT2 inhibitor or those who are diabetic. This might just help for
GLP-1 also will come.
GLP-1.
GLP-1 did not GLP-1 did not
GLP-1
GLP-1 did not traditionally
GLP-1 agonist.
statistically the best performing
First
were
is the
SGLT2.
BMI.
Statistically, either DPP-4 or GLP-1 agonist to any preventive role.
SGLT2 inhibitor is the least understood molecule.
Yes.
More used but least understood.
And it seems to work in every aspect of cardiology, whether it's viral
And
or
nephrologist and cardiologist, direction is given by the diabetologist.